Good evening or afternoon to everyone. Thanks for joining us. I'm Dick Deming. I'm the medical director of MercyOne Cancer Center and founder of Above and Beyond Cancer. Welcome to our weekly cancer education series video podcast brought to you by MercyOne and Above and Beyond Cancer. And we are funded in part from a grant from the Iowa Cancer Consortium. Tonight, it's my pleasure and honor to introduce Dr. Stephanie Cheng. Dr. Cheng grew up in California. She went to Notre Dame undergrad, majored in anthropology, then went to medical school at the University of Oregon. She did her residency in family medicine and then did a palliative care fellowship at George Washington University. She's now on staff where she's assistant professor at the University of California, San Francisco, where I did my residency 40 years ago. And she's with the Division of Palliative Medicine at the University of California, San Francisco Cancer Center, the Helen Dillard Cancer Center. And we happen to have shared a patient from halfway across the country. And I've had a couple of conversations and realized that we have a lot in common in terms of our philosophical approaches to cancer. So I asked Dr. Cheng to join us this evening, give us a little talk about palliative medicine as it fits into cancer care. And then we're going to have a conversation that will take us in lots of different directions. So I invite those of you in person, welcome for those in person. We'll be asking some questions. And those of you who are joining us virtually, if you could type your questions in the chat box. And with that, I'm going to turn it over to Dr. Cheng, who's going to share some slides. And so that we're not using up too much broadband. I'm going to shut my video off while she's presenting, and then I'll come back on and we'll have a conversation.
Sounds great. Thank you so much, Dr. Deming, for the kind introduction. I have so much admiration for you and your team and all of the amazing work you're doing. So it truly is an honor to be with you all this evening. So I'm going to start by sharing my slides. Okay. So as Dr. Deming mentioned, tonight I'm going to be talking about palliative care. And some of you might be quite familiar with this concept already, and for others, this might be a new or relatively new idea. So whatever one's familiarity is with this specialty, my hope is that this presentation and my conversation with Dr. Deming will offer some pearls and be of some help along the way during your journey. So our plan for today. So I'm going to talk briefly about what is palliative care anyways, and how is palliative care different from hospice? And then I'll share some tips and resources. So first, to start off, what is palliative care? So palliative care is a medical specialty that's really focused on improving quality of life for people with serious illness, whatever the diagnosis. So as Dr. Deming mentioned, I currently work at UCSF's Cancer Center. So the patients I see do have a cancer diagnosis, but a lot of my colleagues who do not work in the Cancer Center may see patients with other diagnoses, for example, heart failure or neurodegenerative diseases, just for some examples. And I just want to highlight this next point, that palliative care can be offered at any age and any stage. I think historically, a lot of people associate palliative care with perhaps end-of-life care, and it certainly can be offered towards the end of life. But really, palliative care can be offered anywhere along the way if someone has serious illness or any life-altering illness, really. It can be provided along with curative treatment. So to give you a specific example, in our clinic, we actually see most of our patients are currently receiving cancer treatment. So for example, chemotherapy, immunotherapy, perhaps they've undergone surgery or plan to, and some are undergoing radiation. So it really isn't about choosing either palliative care or oncology care in our case. It can be provided alongside the cancer treatments. And in this way, we really like to view ourselves as an extra layer of support. So what are the core elements of palliative care, and what do we offer? So there's a big emphasis on symptom management, and we really view this holistically, again, focusing on quality of life and anything we can do to increase comfort and increase the sense of support that one is receiving. There's also a focus on advanced care planning, which I'll talk about briefly later on. That's really about thinking ahead, thinking about one's health preferences or desires in what they want along the way in their cancer journey, and also ensuring that the care decisions that one is making with their team are in line with one's values and goals. As I mentioned, there really is this holistic approach to quality of life. So we really like to focus on mind, body, and spirit. So we will commonly talk about things like pain, GI symptoms, other physical symptoms, but we'll also commonly talk about mood changes that are very common, sleep disturbances, also existential questions may arise. Really anything falls under the scope of what we can offer support around in palliative care. And there really is an emphasis on family and community. We want to make sure you're feeling supported, but also you in the context of your family and also your community. And we want to connect you with any resources that might be of service to any of you all. And last point, there's a big emphasis on the team. So at UCSF, and like many other medical centers, we have physicians, nurses, chaplains, social workers, dietitians. We also partner with psychologists and psychiatrists. And then we also have an Osher Center for Integrative Medicine at UCSF, and we'll commonly refer our patients there as well. And I just wanted to pause here and invite you, Dr. Deming. I know you have a very robust team at MercyOne, and I wanted to invite you to share a little bit about your team if you like. I know Tammy gave a wonderful talk a few months ago. I believe it was called Be the Butterfly, talking about palliative care. And I know she mentioned many other team members too. And I don't know if you want to take a moment to kind of describe your team. It seems like a truly wonderful team you have there.
Yeah, thank you, Dr. Cheng. You're right. Every institution probably has a little bit different team members. There's some core team members, and our team includes obviously the physicians with all of the different specialties that take care of cancer, but then there's also the physicians that are involved specifically with palliative care. And then there are the specialty physicians that might be like cardiologists and lung doctors and kidney doctors and physical medicine specialists and rehabilitation specialists. And besides the provider, the doctor members of the team, nurses are a critical part of the team. And we're talking about, the chemotherapy nurses, the radiation therapy nurses, but also a member that we have here is what we call nurse navigators. And at our center, sometimes they're called care coordinators, but a nurse navigator at our cancer center is a cancer nurse who has years of experience being a cancer nurse, who then joins the team of each patient as not only a physical navigator, helping navigate them from one cancer doctor's office to another, but also help navigate the services that we have to them. So not every patient that comes into the cancer center needs to have a mental health counselor and a physical therapist and a dietitian and a genetic counselor. But when a patient needs any of those services, the navigator can be the one who connects them to that teammate at the right time. Yeah, I mentioned several other services right there: genetic counselors, financial aid counselors, dietitians, and those patients who might need physical therapy, occupational therapy, speech therapy, all of those become members of the team. And the first meeting that we have is really one of those critical meetings as you assess what are the needs of this particular patient. Every patient needs compassionate care, but not everybody needs all of the different therapy specialists that we bring onto the team.
Thanks so much, Dr. Deming. And I think you bring up such an important point too, that there can be such a incredible, diversity of services. And it's so wonderful that you have the nurse navigator role and other clinicians who will help patients really individualize their plan and get connected with the services that will best serve them. So that's so wonderful. And right, there is just such an emphasis on the team aspect of palliative care. And one last point for this slide, that palliative care is not limited to palliative care specialists, just as you mentioned, Dr. Deming. Yes, there are trained palliative care clinicians, but there are so many other team members, and so many team members can weave in so many of these components and can have kind of a different slice of the pie of quality of life, really looking at different aspects of quality of life. And I think your team is such a great example of that and offering this just such a depth of a deep field of support for your patients. So our next slide. So why does palliative care exist, and what are the benefits of palliative care? So every point on this slide actually is backed up by research studies, which I think is really exciting that we have that data that shows that palliative care can improve pain and symptom control. It also can improve patient and family satisfaction with care. It also can reduce costs for the individual as well as the health system. Palliative care can also increase the likelihood of completing cancer-directed therapies and staying in clinical trials. And that can kind of tie into, especially the first 2 points on this slide, that, for example, if someone has really uncontrolled nausea, say, they've tried all of the recommended remedies, they're still having such severe nausea, it's making it difficult to perhaps complete the treatments they'd hope to complete or complete the trial that they're in. If there can be a team that can help support someone in optimizing their symptoms and really minimizing the effect of these side effects, that can increase the chance that someone can essentially achieve their goals and complete the treatments that they hope to. And then lastly, I think this is such an interesting point, that palliative care does not accelerate death and may prolong life in selected populations. I know there are actually several studies showing this in selected populations. And I know, Dr. Deming, you are well versed on in many of these studies, and one in particular. And I don't know if you want to share any points that have stood out to you, but one study in particular by Dr. Temmel, conducted a number of years ago, and showed that there was some life prolongation essentially in a study of metastatic lung cancer patients. And I don't know if you want to chime in with any key points that you observed from that, because it was quite notable.
Yeah, thank you for bringing that up. It's really one of the seminal papers that not only demonstrates improvement, but really philosophically helps to explain what happens with palliative care. So a lot of people, as Dr. Cheng pointed out, misunderstand what palliative care is, think it's like, well, you stop all treatment and you go to hospice, and why would we do that? Well, this study took patients with stage 4 lung cancer. Stage 4 lung cancer is treatable, but not curable. So everyone that enrolled in the study, we expected would eventually die of their disease. Now, they're enrolled at the time of diagnosis of stage 4 lung cancer, and they were divided into 2 groups. One group got the best anti-cancer treatment that the team recommended, and the second group got the best anti-cancer treatment that the team recommended, plus a palliative care specialist was part of the team from day one. And to no one's surprise, when the study was over and done, the patients who had a palliative care team member with them scored better on every possible quality of life. So they had better, they had less stress, they had better pain control, better control of symptoms. And that pretty much everybody thought that that would probably happen, because when you get a compassionate palliative care person on the team, that they help to soothe a lot of the symptoms. But what surprised most people is not only did the patients who have palliative care from day one have better quality of life, but they had statistically significantly longer life. They lived longer if palliative care was involved. And when we looked at why that might be the case, the patients who had palliative care involved had a greater sense of control of their destiny, and many of them ended up taking fewer third, fourth lines of anti-cancer treatment. The type of treatment that is being given after they have failed many of the best forms of treatment. And many of us know that in cancer treatment, by the time you get down to the third, fourth, fifth line of treatment, most patients suffer a lot of the side effects and toxicity and don't get much benefit. And so the patients that had palliative care and felt more enabled to be in charge of their own care ended up having longer survival. The third benefit, which is a benefit to the system as a whole, is that their care ended up being less expensive, and there were fewer episodes of financial toxicity because the care ended up being financially better. So by having palliative care on board from the very beginning, patients still got the anti-cancer treatment, but they had better control of their symptoms, better quality of life, longer survival, and less expense to the overall system. So really, really important paper that points to the benefit of having palliative care on board.
Such a great summary, Dr. Deming. Thank you. And I think, yes, so many notable points, and just so striking too with regard to the life prolongation piece, that in the control group, the average survival time is 8.9 months versus 11.6 months in the group with the early palliative care. So thank you for that great summary. Right, let's see if I can advance here. So I know there's a lot of words on this slide, but really what I'll emphasize is that a poll was actually done a few years ago. And what they showed is that when people learn about what palliative care actually entails, 92% would want this for themselves or their loved ones. And I think this is really key because, as you mentioned, Dr. Deming, there can be, palliative care can bring up a lot of emotions for people. There's different connotations, different associations with what palliative care entails. But more often than not, when people learn what palliative care involves, they say, that is something I would be interested in. Focus on quality of life, support, yes, please. And I actually will share that I have a number of patients who perhaps are nervous or anxious when they see me. They don't understand why they were referred to me. They don't know the meaning of the referral. And when I kind of describe and demystify what palliative care offers, I can see their shoulders drop. They kind of relax a little when they hear about what the emphasis really is on quality of life. So again, education is key. And I think not only do we have a role in medicine to educate our patients about what palliative care is about, but I think there's the opportunity for patients to educate their other clinicians. So for example, I will see some patients who perhaps are in an area without palliative care. And, with COVID, of course, the telemedicine aspect of, opportunities to connect by telemedicine expanded so greatly. So we will often see patients from all over the state. But I've had a number of patients who are in areas without palliative care, who perhaps learned what palliative care is maybe from a friend. And they asked their clinicians, could you refer me to a palliative care clinic? And so I think the education can go in all directions. Clinicians to our patients, patients to other clinicians, clinicians to other clinicians. And I think just spreading the word about what palliative care is can really ultimately increase access that people can have to this service. So now we're going to shift slightly to talk about palliative care and hospice. And how are these different? This question comes up all the time. And I think it's very understandable since the palliative care specialty kind of stemmed from the hospice movement. And so palliative care, as we talked about, can really be offered any age, any stage. And so a lot of people find this graphic helpful. Thinking about palliative care as kind of this larger umbrella, again, team-based comprehensive care focused on symptoms and quality of life. And then as part of that, there is the end of life care. You can see the smaller green circle. So we certainly do offer support around end of life. And now hospice services are one very special type of end of life care. So you can think of it as hospice being a type of palliative care. So hospice is palliative care, not all palliative care is hospice. And hopefully this graphic can help illustrate that. Typically, hospice is offered when life expectancy is thought to be 6 months or less if the disease process runs its normal course. Now, of course, we all know that every person is unique and the way they experience their illness and disease process is unique based on the individual. But as part of the qualifications for hospice, this is kind of how it's described. And then in general, those who will enroll in hospice services will kind of agree to forego curative treatments of their terminal or life-limiting illness. So this might be for a number of reasons. Either they choose philosophically this is not in line with their goals right now to continue cancer-directed care, say, or perhaps it's felt by the patients and perhaps in conjunction with their medical team that potential benefit is outweighed by potential harm of whatever treatments. Or like Dr. Deming mentioned, perhaps there's individuals who have tried but been failed by multiple lines of treatment and they feel that they would like to shift focus now to 100% comfort. So what does hospice offer? So hospice really is a comprehensive set of services, and there's a full interdisciplinary team. And now around the country, there are lots of different hospice agencies, and every team will have its different set of team members, but some core members that are on most teams, if not all, are medical director, nurse, social worker, and chaplain. Other teams might have individuals like volunteers or aides. Some teams will have massage therapists, music therapists, and other team members who can also provide support. Next bullet point is that medications are covered. So any medication that relates to the hospice diagnosis is generally covered. Different hospices might have their different formularies, but really this point I list because it's that really the symptom medications for that individual are generally covered. Equipment is also covered. So commonly a hospital bed or bedside commode or supplemental oxygen is covered, and that can be delivered, and the hospice team can really assess on an individual basis what each patient can benefit from. I think this next point is key, and a lot of patients and their families really appreciate that there are staff members on call 24/7. Of course, many medical clinics will have some sort of clinical backup for evenings and weekends, but I think having this level of support from a hospice team has been so meaningful for so many people to be able to have someone that they can reach right away, questions about symptoms or other questions that may come up around perhaps resources. Having that availability is very beneficial. And as alluded to, there's a lot of support for family as well as the patient. And along those lines, hospices all generally offer bereavement support. So after the patient passes away, they have a whole bereavement team that can help support the family and loved ones as they're grieving, and perhaps also dealing with some of the logistics that may come up in terms of funeral arrangements and other aspects as well. And of note, with hospice, one can stop at any time. So I think this is actually really important to know that if you decide to enroll in hospice services, you're never obligated to continue. You always have the freedom to choose if you'd like to stop. In some cases, one may need to stop if they want to go to, say, the hospital, if they're on hospice, but for some reason they there's the need for them to go to the hospital. There might be sometimes when one would need to stop and then re-enroll, but there's always this option to discontinue and then restart if need be. And then there can be some common fears about hospice, and I will just kind of quickly go through these. You could almost view this as like Mythbusters, and Dr. Deming, feel free to chime in for any of these points too. But I'll just start from the top. There can often be this notion that I'm being abandoned. I won't receive any more care. I'm stopping cancer treatments, and so care is stopping. But we really like to emphasize the point that hospice is really a shift in care. So some people actually find they are getting even more hands on deck and more care when they shift to hospice services. As mentioned, there's a number of team members on the team, hospice teams. So many people find, as I note here, same amount of care or more, just with a shift in focus on 100% comfort and quality of life. And I note here, IDT stands for interdisciplinary team, all hands on deck. There can also be the fear that I'm going to die sooner. And as we discussed from the study that Dr. Deming described in detail, that this is not the case, and that in some cases, hospice can be life-prolonging, in fact. I can't go to the hospital anymore. So as I kind of alluded to on the last slide, there can be times where it is, appropriate and desired to go to the hospital, and one would never be barred from doing that if they want to receive care there. And again, there might be some administrative aspects to disenrolling and rejoining, but one would never be barred from doing that.
Stephanie, there's just the comment a little bit on one of those. Tell you what, why don't you complete those? Go ahead. I'll wait till you're done with the next slide.
Are you sure? Okay. I'll answer these quickly. So I have to be at home if I'm on hospice. Certainly a number of people choose to be at home and like to receive services at home, but it's not for everyone. Some people have strong feelings about not wanting to be home and perhaps being at a different type of facility. So some examples are ALF, which you see here is assisted living facilities, SNF or SNF or skilled nursing facilities, or perhaps in the hospital. And there do exist some inpatient hospices as well as residential hospices. And in each of these settings, more often than not, hospice services can be provided. So again, it's not limited just to at home. And similarly, some people actually historically have thought, I go to a hospice only, and that it's going to a place, but they want to be at home. So then we'll try to offer some clarification and education that it can be offered. Hospice services can be offered in so many settings, if not all. And then the second point is I have to stop seeing all my doctors, and that's not necessarily the case. For a lot of people, they have close connections with their clinical medical teams, and so they want to maintain contact. And oftentimes that can be an option. And so there's sometimes some administrative aspects to that to have the team stay involved, but it certainly can be possible. And then lastly, I can't afford this. Thankfully, most insurance companies do cover hospice services. And so these are, again, some of the common fears that can come up, and hopefully these clarifying points can offer some reassurance and additional information about hospice. And Dr. Deming, please, I think.
Yes, so I got a couple of things I was going to say. First, I love that you brought in that the patients can still see their doctor. So for those who don't know, I'm a radiation oncologist. So I treat cancer patients with radiation, but I also practice palliative care, and I see a lot of patients after they've stopped receiving radiation treatments. And for my patients, our hospices here in town are happy to allow me to continue to be on the patient's team. And so I will make home visits for patients that are in hospice home care. I'll make visits to the hospice facility, and as you know, Dr. Cheng, a lot of times that relationship that doctors and patients have is in and of itself therapeutic. And so it's true that those of us who actively treat cancer can still remain involved in patients' care when they go into hospice. The other thing I would say that, some patients feel like, gosh, if I stop doing radiation and chemotherapy, maybe there's that miracle that would happen if I just took a little bit more treatment. And I like to share with my patients that I believe in miracles, but miracles can happen whether or not you take a fifth line of chemotherapy or more radiation. And going into palliative care or hospice care does not preclude miracles happen. They happen every single day, and they can happen in hospice. So you haven't given up your chance for a miracle by going into hospice.
Such an important point. Thank you so much for sharing. Great. So next slide. And now just a few words about advanced care planning, which I know we briefly mentioned at the beginning. So really, this is the process of planning for the future, thinking ahead about what one wants or perhaps what one wouldn't want. And this is an opportunity to really look at one's values and goals and explore that, reflecting on that oneself or with one's loved ones, and also with one's medical team if one so chooses. And in many cases, people will document their wishes. And one can also determine a proxy decision maker if they're unable to speak for themselves. And when it comes down to it, it's really this chance to let your voice be heard. So these are some of the questions that we will ask our patients when we engage in advanced care planning discussions, which is, it doesn't need to be a formal advanced care planning discussion. We really kind of weave it in the conversation with our patients as we get to know them and what's important to them. And so these are some questions we'll often ask. And so I wanted to list these just in case these are of interest to any of you. And as you think about what you want in terms of your care and what you value in your life and in your medical journey, these are some of the things you might explore. So I'll just read through these. How do you define quality of life? What are your values? What are sources of strength in your life? What are your concerns? And then you see here this magic wand question. And how we'll pose this is we'll say, if I had a magic wand and could grant you anything you want, what would it be? And we've learned so much from our patients when we ask this question. And really for all of these questions, as you all probably know, they're very open-ended. There's really no wrong answers. It's whatever rings true for you, what resonates with you. For some individuals, quality of life might be being free from pain. For others, quality of life might be having ice cream with their grandkids. Perhaps for others, it's being able to accomplish a certain activity or be alert and awake. So anything is valid reply. And again, these are just to kind of stimulate your reflection on what really is important to you.
And Dr. Cheng, I would add one other, and it's one that I'm really fond of, this, what brings you joy? Oh, there you go. I didn't realize you had another page. That's a big one for me, and sometimes it's like, what has brought you the most joy since the last time I saw you? And it's amazing how some people I have a hard time thinking about it. And so really you try to help them also prepare for being on the lookout for what brings you joy. Because if you don't ever think that joy can be in your life, and then once I get to know patients well enough, I will tell them your job, part of your job as a human being is today to find joy and spread joy. So it's not just an extra thing. It's part of the human condition to find joy. So I'm glad Joy showed up here.
And Dr. Deming, I think you are such a beautiful embodiment of joy and a joyful, loving presence. And I've so appreciated the conversations you and I have had about joy and the ways that we can incorporate it in our work with patients. And so this question noted here is really dedicated to you. And I'm so glad to you.
Thank you.
And I think it's so beautiful how you really incorporate that in your work with patients, because I think it's so important. And just like you said, when we talk about joy, it's almost like it primes those joy antennas or the radar, where you start looking for joy. So I think such a beautiful point. So just to run through these other questions that one might consider. So what are your goals and priorities? What are your communication preferences? Some people like the big picture. Some people like more the nitty-gritty details. And so we encourage people to, or really invite them to think about, if a certain communication style is important to them, feel free to communicate that to your team. Again, some people might be overwhelmed by all the details, so they'll say, hey, please keep it big picture, and vice versa. Some people feel empowered and perhaps reassured, and anxiety feels lower when they get to know all the details. So any style is valid, and feel free to let your team know. And then the next point, if time were short, would you want to know? Again, there's such individual variation. And for some individuals, knowing their clinician's best guess about life expectancy can be helpful to know. It can be peace of mind. For others, that's the last thing they want to know. And I also emphasize that it's the clinician's best guess. We don't have a crystal ball, but people can share their, again, best estimate of what they would anticipate. And then lastly, when the time comes, where would you prefer to spend your final days? As we kind of alluded to on previous slides, there's lots of different settings. One can be home, different facilities, hospital, skilled nursing, assisted living, elsewhere. So articulating and reflecting on where one would prefer to be can be meaningful. And sometimes it's not possible necessarily to be in that place, but sometimes just reflecting on that, one might learn about one's wishes, and perhaps sharing that with one's loved ones can help guide decisions if and when that time comes. Any other questions or points you'd like to add, Dr. Deming? I know you engage in a lot of advanced care planning conversations with your patients.
Yeah, these are all very good. Your comments about the best guess at a prognosis is good. Some doctors will always say, well, only God knows, I don't know, and won't give any sort of estimates. Others might get really specific on estimates, especially, when you first get to know somebody and they have stage 4, let's just say it's stage 4 lung cancer, for example. Boy, at the time you meet somebody with stage 4 lung cancer, which is not curable, but is treatable, that can go anywhere from 1 month to 12 years. And when you're meeting somebody who is looking good and looking healthy, it's so hard to tell. My mom was diagnosed with incurable stage 4 lung cancer when I was a junior in high school. And this was, in the 1960s, before we had the treatment. She actually lived 7 years with incurable. She presented with brain metastases. And even now, that's, to me, amazing. And I have patients in my practice who have lived even longer with stage 4 lung cancer with some of the modern treatments. So at the very beginning with a stage 4, it's not the time to say with any degree of certainty. And it provides many of my patients comforts to know that, I share the story of my mom. Now, that's not the average, but that when the time comes that you're not doing well, then it's easier to give a more specific answer that is more accurate. But at the beginning, when somebody is healthy and enjoying all phases of life and the idea that we can tell them their life expectancy is not very good. And I agree with you that when the time comes that they have started to have a decrease in their performance status, they're not eating, they're not drinking, they're not getting out of bed as much, I think it's a good thing to be able to share with them that this is the way that we as human beings die, and that most patients with cancer die in an expected manner, and they don't go from being healthy and fit and to just dropping over dead, that there is a slow, gradual demise that they see coming, their family sees coming. And then when that happens, then we can start preparing them that we're dealing with months and then weeks. And then at the time that one stops eating and drinking completely, we can get to be a little bit more accurate in our predictions, which can be very comforting to patients and families to have an idea.
Such an important point, Dr. Deming, and I think you described that so well, that kind of providing that education can be so supportive for patients and their families. Thank you for mentioning that. So a few resources, and I believe, correct me if I'm wrong, that this is a resource you also use, correct? I believe
Yes.
it's mentioned.
Yes.
Yeah, Prepare for Your Care. And so for those where this is maybe a new resource that you're hearing about, it's a wonderful site called prepareforyourcare.org. And this resource was put together by clinicians and researchers from around the country who really put a lot of thought and care into developing resources that they thought would be the most helpful, the most accessible, and include a lot of great content like videos to kind of think about different perhaps medical scenarios or medical decisions. And there's the opportunity to kind of create a document, so an advanced directive. And it's also, there's the option to complete it in many languages. So it's a wonderful website. And see on the top, again, the URL, prepareforyourcare.org. And I believe that at your medical center, you also use the 5 wishes. Is that correct, Dr. Deming?
That's
Do you want
correct.
to say a few words about that?
Yes, so it's really a way of approaching learning more about the family, about the patient and their family, their desires, their how they would like to be cared for. I tell patients as we are caring for them ourselves, we just take care of you the way we would like to be taken care of. But the first thing we need to know is, how would you want to be cared for? And what are some of the important values? And in all honesty, Dr. Cheng, I think you could probably list the 5 wishes more quickly than I can. But our palliative care specialists and our palliative care nurses use that as a tool as we're doing our advanced care planning.
Yeah, and it's interesting. When I first started at UCSF, we used it quite frequently, and then UCSF developed their own advanced directive, which certainly incorporates aspects of it. But yes, the 5 wishes, there are kind of different sections of the form which kind of help people kind of frame different aspects of what they would want. So the first wish that they note is really about who would be your medical decision maker or your proxy. And then kind of going through different sections, there are different emphases. So in some areas, it's more focused on resuscitation preferences. And then perhaps it's also on more generally what one would want for their medical wishes or medical preferences, and then how they would want to be remembered and how they'd want to be cared for in their final days. So a lot of great details and example language too. And when we would use this form, we'd encourage people to, if they'd like, fill this out with other family members, spouses, children, parents, friends. And they, as I mentioned, give some example language, and feel free to, cross out what doesn't resonate with you, add in what you want to add. This is your document where you get to really articulate what's important to you and what you would want. And so there's a number of wonderful resources out there. The Prepare for Your Care 5 wishes are just two great examples, but I know that there's a lot of wonderful wishes out there. I'll mention, I don't have a slide on this, but I learned about this from a colleague. There's a website called Join Cake, and I've been told it's very, quote, millennial friendly. And it's kind of like an online resource that includes a lot of these elements that we're talking about. It incorporates things too, like your social media passwords and legacy, and who will manage that. So all of these different elements, but a lot of the more traditional elements like medical decision maker, preferences around perhaps life support or resuscitation, other medical wishes too, funeral services, if one wanted cremation or body donation. So lots of different aspects to that too, but that is Join Cake. I believe it's joincake.com, another resource out there. And the last resource I have listed here is getpalliativecare.org. And this is a nice resource that just kind of, again, describes what palliative care is, talks a little bit about the different services offered, has some handouts for patients and families. You can see in this screen some podcasts, and then helps one locate a palliative care team or some different local providers that can offer services. Again, you have such a wonderful, robust team there. And this can be just a nice educational resource. So just for some final thoughts, I just wanted to share that one of the reasons that I was so drawn to palliative care really was this emphasis on each individual's experience and accompanying patients on their journeys. And this real emphasis, as you alluded to, Dr. Deming, on compassionate care and really being present with the human in front of us and doing all that we can to support them in maximizing quality of life and helping them feel heard, supported, and held. And yes, we are, we can be a clinician and patient, but at the end of the day, I really think it's about human and human. And so I'm just so honored and grateful for the opportunity to serve my fellow human being and to accompany them on their journeys. And so I'd like to end with this quote by Desmond Tutu. "My humanity is bound up in yours, for we can only be human together."
Yes, beautiful. Ubuntu, I think is the African phrase for that. That yes, we are bound together. Well, this has been great. I'd like to just engage in a little bit of conversation. Maybe have you talk a little bit about some of the conversation techniques you use. I already shared with you one of mine. Like, I like to talk about joy. I like to get patients to ruminate on what really brings them joy and try to help them as they describe, point out to them that most of the things that bring people joy ends up being helping other people and being engaged with other humans. And I so agree with you that the act of even providing medical care is human beings taking care of human beings. And patients recognize when the person who is giving them care is a human being who cares about them. So that compassion and joy are things that I work into conversations. And I'm not doing a very good job right now, but I listen, and listening can be an act of compassion. But I'm interested in some of the techniques, maybe some of the topics that you find engaging patients in can be therapeutic.
I appreciate your question. I think certainly talking about, what brings one joy, what brings one strength and allows them to feel supported. I will share that, in terms of topics and themes, something that has come up a number of times over the years is this idea of self-compassion. And what I found is that, we humans do have this tendency at times to beat ourselves up for this, that, and the other. But I've noticed that practices of self-compassion have really resonated with a lot of my patients. And so to describe that in a little more detail, sometimes people will feel like, I think there's so many scenarios where this may have come up, like, oh, am I doing a good enough job with my treatments, or am I doing all I can? Am I exercising enough, or doing X, Y, and Z enough? And again, this self-critic can come up for all of us. None of us get spared that. And so I think there are many wonderful self-compassion practices out there. And I know it's kind of a growing field of research and clinical practice. And I've seen that offering oneself compassion for what one is going through has been very meaningful for a number of my patients. And so what we'll sometimes do in our sessions is we might do a quick, maybe 3 to 5 minute exercise, where the exercise might involve, thinking of a difficult situation or something that may have come up, and then kind of offering oneself perhaps language one would offer to a good friend going through a similar difficult situation. And a lot of this work has been, one of the pioneers is Kristen Neff, who you may have heard of, done so much in the world of self-compassion. And she has a number of fantastic resources online and audio files even that are free and accessible by all. But I've had so many people come back and give me feedback that cultivating this voice of kindness to oneself has been very meaningful and even transformational at times. And sometimes it might be a matter of, a patient is I'm experiencing so much pain and nausea right now, and this is so hard. But having that voice to soothe oneself and be like, you know what, sweetheart, you're doing the best you can. This is hard, and you're being so brave and so resilient. I'm so proud of you. And, there's whatever language resonates with that individual. It can take so many forms, but that's what comes up for me as you posed your question, Dr. Deming.
Yeah. One of the other areas of conversation is, I often help patients explore the philosophical dimension of being a human being. And that includes, spiritual. They're probably different, but in some ways, how you view, what does a patient think is going to happen when they die? How do even the concept of mortality? So many different philosophical, from the Stoic of memento mori, that remember you will die, a reminder to all of us that we're going to die, not as this depressive bummer of a notion, but with the idea that we are not dead yet, and that there will be plenty of time for death, but that we are alive today. And memento mori is an acknowledgement of mortality, but it's really a call to live today, because regardless of whether we have cancer or not, there will come a time when we are going to die, and that the opportunity to realize you're alive today and to embrace living today. So that's just one area of philosophy that we will often talk about.
I love that. And I love the emphasis you bring to really living for today and being present in this day and this life, and being present with one's aliveness.
Another philosophical concept, again from the Stoics, is amor fati, which is to love your fate, to realize that, we're not totally in control, and that things are going to come, and there's going to be hills and valleys, and that to always wish that you're going to be standing on top of the mountain is not the case, and that to just take what comes. And there comes a time where getting in the middle of the river and going with the flow can be very soothing, that, trying to swim against the stream all day is very challenging. And sometimes going with the flow and just getting in the middle and going with the flow can be soothing.
And such a beautiful and perfect metaphor for that, of getting in the river.
So we're coming to the end of our hour, and I just wanted to tell you how much I appreciated your talk, and your essence comes forth. I'm so glad that you found oncology as the place that you wanted to practice palliative care. Your patients are very fortunate, and I look forward to collaborating with you some more and learning. We're in the verge of opening a new center that's going to have expanded opportunities for patients living with cancer, for bringing integrative medicine, palliative care, compassionate care into the setting, and you serve as a great example. So thank you so much for sharing your philosophy and your professional skills with all of us today.
Well, thank you so much, Dr. Deming. It's been such a pleasure, and yeah, a true honor to be with you all, and I wish you all the best.
Great. Thank you so much. And for our audience, thanks for attending this evening. This video of this video podcast, a recording of this podcast, will be available for you or your friends to watch, and you can find it at the MercyOne Cancer Center website or at the Above and Beyond Cancer YouTube channel. And please join us next week for our next video podcast. Thanks so much for joining us. Take care. Bye-bye.